there's some centers that are adamantly against it. So what's interesting to me in the industry is that there's like, I feel like there's a degree of dogmatism that comes up, and it could be in one direction or another about like either like yes 12 steps or no 12 steps, and that's part of how, like, when I'm referring people into treatment, it's like I actually like to ask them like how much spirituality would you like as part of your as part of your treatment, because if you like it, 12 step is great and there's a lot of research and evidence behind it, and that's fantastic. And if you don't, there are other ones. But I think that there are places that fall into the trap of being like, either you got to be like there's one right way to do it.
And you're right, and that's true for everything, right? There's no one size fits all for treatment. It's customized approach. It's not like, oh, you need medicine or you don't need medicines, or you need 12 step or no 12 step, if it's working for you. And that's the trick. And I guess the art of it all is finding the right match.
Yeah, and I think that that what I found really bizarre about it, though, is that doesn't go along with like any other type of medicine or even behavioral health. Like you've got tools, right? You've got a bunch of different prescriptions. You might have different procedures. There might be a lot of ways to get where you want to go, but it's not like people are being like overly, like if someone chooses one antibiotic over another, if both of them have evidence, it's not like anyone gets mad about that,
Right. Yeah. My son was just in a bicycle accident. He broke his clavicle.
Oh, I'm sorry.
I know, poor guy. Oh. But one person suggested surgery and the other one didn't. You'd heal both ways, and it's just a matter of, finding the right, choice for you, but understanding, both sides. And that's a trick.
Yeah. All right. Well, we are a couple minutes in, so why don't we dive in? Thank you, Dr. Roneet Lev, for joining me today. I really appreciate you taking the time to do this podcast.
One of the most honor and fun to be with you.
Well, thank you. So you took a really unique professional path through life. You've been up in some of the highest offices and places in the country at the Office of National Drug Control Policy. Now you're down right near the ground. You're working with people directly in an emergency room. I'd love to cover both of those places today, both of those systems today. Let's start though with the 30,000-foot view. What brought you to ONDCP, and what did you pick up while you were there?
It's interesting you bring like from down to the top, but what brought me to that is I don't have addiction in my family, and so I didn't relate to that. I didn't really relate to people who have addiction in the emergency department in my early years. But in 2005, one of our neighbors and friends, Aaron Rubin, 23 years old, overdosed on oxycodone. He had a sports injury in high school, same high school my 4 kids went to. And I remember visiting him. It happened on Yom Kippur. We were all talking about it. And then I visited him in the ICU the next day, expecting him to die. He was on a ventilator. He had strokes. He was in bad shape. But he didn't die, became a quadriplegic, and his mom became a real advocate on the issue of the opioid prescription epidemic. And years later, she asked me, why are doctors prescribing all these medicines? I was one of those. And it's like, because, patients ask for it. They say their pills fell in the pool. Who am I to tell them that their, opioid pills didn't fall in the pool, and that their doctor's out of town and they got lost in Disneyland and all these excuses. I was part of the problem. And I realized that, there's a different side of the story. I was seeing patients in the emergency department who were angry and demanding their medicines, threatening me if I didn't give them their opioids. And I met this whole group of parents who were angry, hurt, injured by the medical community. And I've been a leader in medicine. I've been a president of the California chapter of the American College of Emergency Physicians, and locally I established groups that bring all together all our emergency departments. And I had the skill set. I thought that I could do something about it. And that's what brought me to that. I wanted to deal with the medical component of the opioid epidemic. And of course, that resulted in me becoming board certified in addiction medicine. I did things just locally in my community in San Diego, and that spread to out throughout California in safe prescribing. And then I was helping other communities, and that led to the job at the White House.
Yeah, well, and I think the opioid epidemic, it really has brought a lot of us together around this concept of addiction. And I think that it's certainly something that's not going away anytime soon for a number of reasons. If anything, it's actually getting worse in terms of overdoses, in terms of substance use across the country.
Right.
So
Well,
question
you're
for
right. It was a silver lining having the medical community. This is the first time the medical community was engaged in solutions for the issue of addiction because we were part of the problem. But I would say that now, actually, I feel like I've accomplished that mission. We don't have an opioid prescription epidemic anymore. We still have room for safe prescribing, and we still have a horrible, the worst ever addiction and drug overdose problem. But that little piece was solved.
Right. Yeah. So I wrote an article actually. It's almost been a year now, but I published it in Newsweek back when we first saw this big jump in overdose death.
It was a great
It was,
article.
oh, thank you. I appreciate that.
It
And that's
was.
actually, I think, why I came on your show. But I was looking at this and saying, I think that we addressed that initiation of the problem with the prescribing, but we're still seeing these overdose deaths. And the point I was trying to make at that point was I think we're ignoring the middle part where people get worse and problems increase over time. I'm wondering, from your time working in Washington, being part of ONDCP, what are your thoughts on this escalating crisis where people are, I think there was a paper recently published that said we're on track to lose 1.2 million more lives due to overdose in the next 10 years if things don't change. What's your take on what need? I know there's no silver bullet, but what do you think needs to change?
And first of all, it's tragic. And not everybody who's dying has a substance use disorder. Some people are just experimenting, don't even have an opioid use disorder and dying from fentanyl because fentanyl has infiltrated the entire drug market, including marijuana. I just saw a news report today from Maryland where they're warning people that marijuana is laced or contaminated with fentanyl. So that's what makes it tragic. Are you asking me for, if I had a solution, what would that magic solution be?
Well, less of a magic one, but more. So
Well,
you've been in
I would
rooms
say
that.
you study history, right? First of all, what the opioid prescription, I just said the opioid prescription epidemic ended. How did that end? We controlled supply, and we instituted prevention, right? That's how it ended. We didn't interdict the drugs. We didn't buprenorphine our way out of that problem. We instituted safe prescribing. We decreased the amount of opioid prescriptions out there, and that solved the problem, right? So you have to, if you really want a solution, you have to do it at that front end. So, using the opioid prescription epidemic, we had two patient populations that I was seeing. One was, the person with back pain or a headache who was on a huge bag of medicines and high dose opioids. What do I do with that patient? You don't cut them off. You manage them and keep them alive, and play with things. You may never get back to normal, but you just keep that patient population going. But if we wanted to end, this was my thinking at the time, if we wanted to end the whole problem in the first place, it has to be on the front end. We have to treat back pain differently. We have to treat headaches differently. We have to treat pain without opioids. And we did that. There's like amazing innovations, and we massively cut the amount of opioids and probably had a positive effect on pain at the same time. And so that was the formula. So if we want to apply that same formula to fentanyl, then we have to, it's not going to be solved with treatment. I mean, treatment is important. People who have a problem need treatment with compassion, without stigma. But we have to, one, cut off the supply of fentanyl into our country, make it like, treat the people who are bringing precursors over and fentanyl over, the high-level dealers, I find them as terrorists and murderers, right? Their financial supply has to be cut off, and do that and treat prevention in our youth. So we treat our kids kind of like I said, okay, if you have back pain, how are we going to treat that without getting into opioids? We can, create resiliency in our youth, so they're not tempted to go into marijuana and other drugs. I have not met a single patient who uses fentanyl or overdose on fentanyl that didn't at some point in their youth start on marijuana. So that would be my approach to the situation. Do we have the will to do that as a country? I don't know.
Yeah, well, and I think that figuring out how to crack that code is really important, and the proof ultimately is going to be in the pudding, where our deaths going down, our use rates going down. Right now, the answer is no, and I think that means we're missing that key ingredient. I interviewed Sam Quinones, I think you did as well, actually, about the fentanyl influx and what that's looking like, and it's true. Like now that it's here, now that it's infused into everything, that's what's driving so much death right now. But I know there's something else actually. This was a topic that I actually tried to get an op-ed published on this back in November of last year, but couldn't find a partner for it, on the youth mental health crisis. That at that time was being announced by the American Academy of Pediatrics and the Surgeon General, and only now, I'd say in the past month or so, are we really seeing some traction in the media about this. I think that you mentioned you've got the supply side with the fentanyl, and then you've got the demand side with the prevention and the resiliency and the coping. And I feel like we're seeing almost a perfect storm of inaction and problems where both sides of this are not being adequately addressed. And if anything, they're surging. So while we've got the prescribing under control, we'll call it like the precursor factors that lead to addiction and eventual overdose, they're still flowing into the country freely.
Well, we're a divided nation on a lot of things, but also on this issue. I mean, there is groups who want to normalize drug use, and if you're pushing drug use on parents and adults, and what are the children going to see? Right. So I mean, that's a failure. That's a formula for failure.
Mm-hmm. Yeah, I will completely agree. But I want to make sure that we talk about what your experiences are in the emergency room as well, because this is a unique vantage point. Much like you've been in Washington working on this, you're also in emergency departments
Yes.
right now. And so what are the trends that you're noticing with the patients who you're seeing? How is this coming out in real life right now?
And by the way, when I was at the White House, I was still flying back from DC to San Diego and working clinically in the emergency department. I didn't want to lose that skills. And it was very interesting because our mission at ONDCP was saving lives. And, people saying, oh, isn't DC such a stressful event? It's like, no, people on the ground in the emergency departments around the entire country, they're the ones who are really saving lives. And that's a much more stressful job. But yeah, the biggest problem I see in our emergency department, not just mine, but throughout the country, is mental health. Right. So you were mentioning youth mental health. There'll be, a 12-year-old living in an emergency department for weeks because there's no place for them to go. Not just kids. I had a patient 2 weeks. I was the one who got to do the discharge, sitting in our emergency department every day, getting up. I'd go see him. And he's like doing jumping jacks in his little room in the emergency department. And can you imagine somebody who has psychosis or depression? What's the worst place that you could put them in, right?
I know,
A loud, busy emergency department. It's a terrible place. And that is the biggest problem we have in emergency medicine. And for each person who's sitting in that room, there's less people able to come in from the waiting room, especially if they're being there for a long time. Mm-hmm. The other, and it's an intersection problem in the emergency department, is of course issue of drugs. That never went away. Even when we had no patients in the emergency department, we were shut down with COVID, waiting for the tidal wave of patients. The people who had substance use disorder or were intoxicated were the ones who were coming in the emergency department. And as far as killers fentanyl, of course, is driving, deaths and overdose. So we're seeing that. I'm hoping to see that, right? Because if they come to me, they have a hope, right? I'm going to do my, darndest to keep people alive. Unfortunately, 2.5 patients a day in just San Diego County end up at the medical examiner's office.
Yikes! Yeah.
But every single day, every single shift, I'm guaranteed to treat someone with some drug-related problem. And every day, every shift, I see cases of marijuana poisonings. And I can tell you what that, people go, marijuana poisoning, what's that? But every single day we see that. So most common marijuana poisoning I see is cannabis-induced psychosis. The high potency, people think of marijuana, so it's just weed, just marijuana, but those high potency THC products, those shatters and concentrates and vapes, those act more like methamphetamines, and people come in with psychosis. Every day, every emergency department across the country will see cannabis hyperemesis syndrome, people with horrible abdominal pain, vomiting, because their cannabinoid receptors are messed up and acting erratically. We see pediatric exposures, kids, babies get into their parents' drug supply. 4-year-old got into a little, his mom's gummy, ended up in the ICU.
Yeah.
So there's been a 13.5-fold increase in pediatric exposures to marijuana. Seizures, somehow out there, people think, oh, I need to use marijuana for my seizures. But if you read the FDA label for Marinol, which is THC, you'll see it actually decreases the seizure threshold. So I'll see people who have a seizure disorder, and maybe they're forgetting, or maybe they're taking their medicines, but they're in there for seizures. Drug driving is a problem. Drug interactions, cardiac effects. I've had patients who've come in as a stroke code. People think they had a stroke, and we do all the stroke stuff, and it's all negative, and it was all because they had a weird reaction to marijuana. So
no, I mean, and I know that's a subject that we're both very passionate about, is really trying to educate the public about what's going on the THC and marijuana front, because it's such a fast moving target. There was something that is kind of mind boggling to me about that. We'll take a little digression down that path for a second. So just yesterday, I believe it was, we saw a news article about how the FDA is considering removing menthol cigarettes from the market.
I know, I laughed at that.
I know, because it's like
that's the big crisis, menthol cigarettes, right?
Well, I mean, the thing about that is, right, is it's like the policy on that, though, like, is going in a completely different direction, and in a good one, right? Like, you remove
Never
access.
mind the mango flavored vaping, that's okay.
I know, like, that's okay. And then the THC that's just being, there was another article that came out, I think about a month or two ago, that actually was even more shocking to me. And I'm plugged into this. It was looking at the impact of recreational marijuana on cannabinoid-induced psychosis. And they were looking at hospital discharge records from 2017. And they found, actually, they were looking at a national database for this, that there were 129,000 cases of cannabinoid-induced psychosis that were discharged from U.S. hospitals in 2017, which comes down to 1 every 4 minutes, which is outrageous when you think about it. That's a tremendous amount.
I'm impressed that they were able to get that data, because I think that we are under capturing that. I know that I've only recently started calling it cannabis-induced psychosis. I would just put in my coding psychosis, and my talk screen would be THC. I never put that together for some database to pick it up.
Yeah, so that, I mean, it might even be underreported.
Yeah.
But that was even more, I mean, so I was the director of an addiction service line at a hospital for 4 years. And while I was there, we had about, it was like a 40-bed inpatient unit for adolescents. I'd say there was between 2 and 5 kids in there at any given time with cannabinoid-induced psychosis. So I knew that this was going on, but the scope of it was much greater than I had thought, from before I'd seen that paper. So, I mean, yeah, it's incredibly intense. Here's a question, though, about what you're seeing in the emergency room. So you see these folks come in, whether or not it's with a marijuana problem or an alcohol problem or an opioid problem. How do you feel about the linkages between when they're coming in, they've got this touch point in the emergency department, where they've come in contact with the medical system, with the healthcare system, how well do you feel like we're capturing people and actually getting them down a track that can lead to recovery versus kind of just returning them to the wild and maybe even having them come back again within a few weeks?
Right. And by the way, in San Diego, our number one drug that I didn't mention is methamphetamines. I don't think we're doing a good job, but I think we're getting better, right? So
Mhm.
years ago, before the opioid prescription epidemic, we probably did a terrible job, right? You know, our discharge instructions were like, don't use alcohol, don't use methamphetamines, and and then you're right, go out to the wild. Now I feel like we're um, trying, retrying.
Yeah.
So we have in our emergency department, not across the country, because you need a partner. So each emergency department can't act alone. I see this in government too. Well, let's just make the ERs do this. It's you need a partner. Where are we going to send them? Well, we could start
Right.
buprenorphine in the emergency department, but then what? Right? So you need to have a community partner. But this is
Yeah.
increasing across the United States. And in our emergency department, we have MAT programs. We have substance use navigators to connect people to treatment. We even purchase for a while, we were purchasing outside beds for alcohol and other detox from the
That's
hospital
great.
account to pay for patients for that connection. So definitely getting a lot better. The emergency department is like you said, it's a touch point. Some people are just not ready, right? They don't see it,
Hmm.
right? I mean, I had a guy who was on a naloxone on a Narcan drip. He had an opioid overdose, probably fentanyl. I'm sure fentanyl, right? And he kept falling asleep and overdosing in front of me. So give more and more and more naloxone to wake him up, and it
Yeah.
wasn't enough. So at some point, we said, okay, we put you on an actual drip. We have naloxone continuously infusing in the vein to keep you awake. And this guy woke up and it's like he thinks, okay, I'm okay now. I'm going to put my pants on and walk out. It's like no, you're connected to
Wow.
your life support. You don't always, when you're in such a critical state, you don't always have the insight
Yeah.
um, to understand that. Yeah.
Right. Yeah. And I think that there's that moment of crisis, and not even just crisis, but maybe even like going in and out of consciousness or wakefulness or intoxication.
Yeah.
And it's challenging because sometimes this is where some of the only time these folks intersect with the healthcare system, because they tend to not come into primary care, maybe for obvious reasons.
Right.
And so it's challenging though, because like you're saying, there's only so much an emergency department is designed to do. You guys are more of like a stabilize and discharge, whether or not it's up to a med floor or out onto the street. Like people don't stay with you and you don't follow people. But particularly when it comes to addiction, this is something that people actually need to be followed for, because they might not be ready to change in that moment.
Right. And addiction has a component of denial in it too. I went to a really cool event yesterday. And there is a man named Chris who used to be addicted to methamphetamine, cleaned up and wanted to give back to the community. And he cooks food for the homeless. He brings his van. He calls it God's Kitchen. I'm going to have him on my podcast, but and he makes food, ribs, mashed potatoes for 100 of people. And he noticed that people who were coming, he calls them the brothers and sisters, were dying, and he asked the county and the DEA to help. And so we came right with his van. He's cooking food to people, and right next to the van, there was naloxone, fentanyl strips, yeah, and people from the community being there saying, offering help if they want it. So that I thought that patients there, those people lined up, such a beautiful line. No one's pushing or shoving and getting food. That I thought that was a better way to engage, in
Hmm.
in care rather than in the hectic time of the emergency department. Although
Oh,
we need
definitely.
it both places.
Yeah, yeah, for sure. I mean, gosh, I spent about 3 months in an emergency department for quite some, like 20 hours a week. I was actually piloting one of those navigator positions you were speaking of, and there is so much. I just want to say first of all, I am so impressed by you and what you do in emergency medicine, because just being in there for 3 months was like, oh my goodness, the ability for you folks to keep your morale up and to keep coming back despite wading through all of this really intense human suffering and keep helping people and to keep having a positive attitude. It's absolutely incredible. But
Thank
it's
you.
also really hard, yeah. But it's also really hard from the patient perspective then to necessarily have any time to think. It's a very intense place to be.
Mm-mm.
So I completely understand that. Um, so a question though, then also about culture and about stigma. So one of the things that I noticed when I was in the emergency departments in my hospital system was that there was a lot of misunderstanding and a lot of stigma around addiction. It almost seemed like the patients who were there for addiction were a nuisance, and I would hear things like, there was a gentleman who came in with a blood alcohol content. He had alcoholism, and so it was like up around like 0.4 something when he came in, and in the morning it was down like
Nice,
around like,
but not the best we've seen. Okay.
oh yes, no, it can get up over point. I think the highest I saw while I was
Okay.
there was 0.54. And he was alive. But it was like 0.4 something, and he was coming down over time. He'd been there overnight, and he was down around 0.3 or a high 0.2s. And the staff was actually saying, we need to discharge him quickly so that he doesn't go into withdrawal, so that we don't have to admit him. Like, let's get him back out so that he can start drinking again, he can stabilize, because we don't want to have to admit him.
That's the
Um,
classic teaching. If there's a window where being
yeah.
intoxicated and being in withdrawal.
Right. But to me, that's kind of like saying, so you've got someone who's having like an acute exacerbation of their illness. Like, this is something where this person is clearly suffering. Why are we not thinking, like, why would admitting him be such a bad? I can understand beds are sometimes at a premium, but like this man clearly needs help. And to me, it was just this dismissal of the fact that he could recover, that he might actually get help if we gave him a chance. How do you feel? What have been your observations about looking at the culture in hospitals, emergency departments, and where do we go from here?
So let's talk about your patient first, and then we could talk about the culture. Um,
Yeah.
I did the same thing for years. There's a narrow window between addiction and withdrawal, and get the patient discharged at the same time. Um, our hallway is full of those patients. I mean, we cannot
Yeah.
admit them all. We just can't. I don't think that that's our job. But what we do differently now, what I do differently now, is when they are in that window, when they're able to walk and not fall over, um, I'll ask, do you want to get sober? Right? I'll
Hmm.
ask the person. At that point, they can make a decision. Are you going to go back to drinking? Yeah, or never mind, or whatever. Then I'll let them go. If they want help, then I'll provide it. Right?
Yeah.
At that point, I'll provide it. Let's talk. And actually, I've changed what I do now. I used to give Librium for detox, and then I found that the number one drugs per prescription in deaths is actually Librium. So I'm like afraid to give that.
Really? Wow.
And I'll ask a patient if I'm going to give something for withdrawal. I say, if you're going to drink alcohol, just drink. I don't want to see like my name on a prescription in the medical examiner's office, right? And say, I'd rather
Yeah.
have you just drink alcohol than take alcohol and Librium thinking you're going to sober up. And I'll ask, we have case managers now in the emergency department. So if they want to I can, see if we have beds. Sometimes we do, sometimes we don't. That
Hmm.
I can get you to a detox facility. And prevent the withdrawal. I mean, withdrawal is a terrible thing. You don't want to go through that. So so preventing admissions is important. So that's how we
Hmm.
used to do things, and that's how we've kind of done things a little differently. If you're ready
Yeah.
to sober up, we can, we can try. Um,
Yeah. Well, that sounds very balanced.
Yeah. So, as far of the issue of stigma, it's still there. I would say that we need to understand the stigma from both ends. On the provider's end, why do we have stigma? I think it's our own frustration. Ugh, another homeless person. What am I going to do for a homeless person? It hurts us. I'm going to send these homeless people to the street I have nothing I can do about it. It's terrible. I mean, it makes you feel like a bad provider, and yet that's a situation that we're given. So it comes off as stigma. It's because we have nothing to do, and it's our own frustration. Oh, another drunk guy, taking up a bed. Okay, well, what am I going to do? I can't fix your alcohol addiction, so it comes off as stigma.
Mm.
But if we give that same doctor, I mean, we're all like sacrificed a lot, the doctors and nurses, to be in that emergency department. If we give them something to do, it makes you feel better about yourself, and it helps with the stigma on our end. I have a homeless person.
Mhm.
I can give them a sandwich and some socks now, and a list of
Mhm.
places to go, and so it's like, oh, I now there's something for me to do, and that it helps. That the same with alcohol, same with same with drugs. That's on our end. Um, Stigma can be a slippery slope, right? Because you don't want stigma for the human being. It's a human being in front of you. They deserve compassion. They deserve treatment. So, I educate eliminating stigma through clinical understanding. If you understand that addiction is a chronic, relapsing, treatable disease of the brain with a relapse rate similar to asthma, hypertension, diabetes, that helps the understanding. On the other hand, we do want stigma for using, right? Don't smoke. That's yucky, right? We all agree with that. Even if you have friends that are smokers, they'll go do it in another corner. Using tobacco and the act of smoking deserves stigma. You as a human being don't. And I feel like as a
Mhm.
society, we're mixing that up. And that's where the normalization of drug use comes in. Like, we don't want stigma on the user, on the human being, but we don't want people using drugs.
Yeah, well, and I think it's honestly, I think it's very courageous for you to say that. I'll also say that I agree with you on that. I think that when you overly normalize something that is inherently unhealthy, then there are negative repercussions of that down the line, and it kind of treads a little bit far into this overly accepting culture. And I think that I know that you and I both have come up against that in some of our work and advocating for prevention, and that actually normalization is like the direct opponent to prevention, saying like, yeah, like getting using drugs of any variety is just an okay thing to do, is very
Yeah.
different to say than you are still an okay person even if you're using drugs. Those are two very different things. It's not that someone is blighted as a person, but certain activities absolutely can, if you promote them, cause a lot of problems particularly when you broaden them out over the population level, but even individually, it's an issue.
Yeah.
So yeah, all right. Well, I appreciate that perspective. And let's scope down now to California specifically. There's a couple of bills that you have that are going through the state, and oftentimes California is right on the front edge of doing things differently, sometimes innovatively. And so I know that you'd want to talk about these things, and I'd love to hear your opinion on this. One has to do with a new bill just made it out of the Senate Health Committee, would require hospitals to test for fentanyl I think it was overdose cases more broadly. And I know when I was reading about it, I had mixed feelings about it, because I've been in situations where bills, although they sound good, end up being more like stage props and theater than anything else. Let me give you a quick example. In Michigan, while I was working there about a decade ago, they passed a law that allowed for people to involuntarily hospitalize someone for addiction, which at the time you couldn't do. If someone was an immediate, imminent threat to themselves or others because of an addiction, that allowed for a 72-hour hold, much like if they were homicidal, suicidal, or psychotic. And that was actually something that was it was very popular. It was something that was a slam dunk for the sponsors of the bill, but they actually didn't fund any mechanisms for making it work. So although they passed the bill, I'm not sure if even to this day it's ever actually been enacted in any way, because
Yeah.
there was no mechanism to actually do it. And so in this case, fentanyl testing, particularly fentanyl test strips, we've got really good information that says if people have those in their hands, they'll test their product. If it comes up positive, they don't want to die, they won't use it. What do you think, though, is the utility of testing for fentanyl in hospitals, and how do you feel about that bill?
All right. So first of all, I agree with you and your instinct of being suspicious, okay? Because the devil's in the details. And when you read something, it's like, oh, this sounds like a great idea. And then you read the details and it's like, I don't agree with that. And what's the catch? This is different. I'm going to change your mind because I wrote
Please,
it
please.
myself. I wrote it myself.
Oh my gosh.
This is my first bill. I came out of, White House. I was like, I want to make a difference. So this was my idea, my project. I wrote it. It's not this long bill with all sorts of loopholes. It's short little paragraphs. It doesn't mandate any testing in the hospital. So my bill is just hospital related. So here is my premise of getting to this bill is we're doing drug testing, and our drug tests include the federal 5. It includes marijuana, cocaine, methamphetamines, opiates, and PCP. If you're going to order a drug screen, and I'm the last one to tell a doctor what to do, but if you're going to order a drug screen, why would you not include fentanyl if that's 80% of people who die of fentanyl? Why is it not in the drug screen? And it's not in the drug screen in the majority of hospitals and clinics around the entire United States.
I see.
So I met on a quest of like, why is this the case? Can it be fixed? And I contacted the FDA and found out that there's no FDA approved multi-drug strips that include fentanyl. I even went to why.
Oh.
I contacted some companies to find out why. They said we have it, but it only tests for 5 nanograms per milliliter, and the FDA requires 1 or 2, so they don't approve it. And I called FDA and said, I got 0 nanograms now. I'd rather have 5, but I got shut down. On the other hand, in a hospital setting, every hospital in America, rural, it doesn't matter where, they all have a chemical analyzer. And there are 3 FDA cleared fentanyl reagents, and they cost about 75 cents each. And you could put that in your chemical analyzer and include that in your drug screen. So then I went to test this model within San Diego. San Diego has 24 hospitals. I called every single one of them, talked to their lab director. This is the middle of COVID. So they all were COVID. And I said, I know COVID, but can you just ask about fentanyl? And they agreed. Now, after short education, creating a toolkit on how to do this, the majority of hospitals in San Diego County include fentanyl in their drug screens. So if you're going to test, we're not telling you to test, but if you see a patient, you're going to do a drug screen for whatever reason, it should include fentanyl. That's a no-brainer. And so that's why I got unanimous support. Nobody opposed it. In California, a very contentious state, Republican and Democrat co-sponsorship, went through appropriations also, and Senate Health. And the bill is named after Tyler. I met Tyler's mom, whose son died of a fentanyl overdose. So it brings a human aspect to that. It's approved by the emergency physicians as well. The nurses are, it's part of their alleged day. So hopefully I changed your mind.
Oh my gosh. Yeah. Well, hey, as soon as you said you wrote it, my mind had already been changed. I know that, you're in this for the right reasons. But
and it's separate from fentanyl testing strips, right? So that's different. My bill is, testing urine on people, right, who are using. Fentanyl test strips are for the product. And that is, again, no one size fits all. First of all, some people openly want fentanyl, so they don't need this test strips, right? So we can't mandate that. I mean, it should be legal. For some people, that's considered drug paraphernalia. We don't want that. I mean, we want to give that out. Some people are thinking that they're using methamphetamine or cocaine, and those are the people who should really be using the fentanyl test strips. Okay. But it's not 100%. And it's not 100% for a few reasons. One is you got to mix it right. And, maybe the fentanyl's on this corner, not that corner. You have to use it right. So it's going to miss. And also there's other drugs besides fentanyl that are actually even stronger than fentanyl. And we've seen that here and there. It's not an epidemic yet, but it could be. We're seeing it, like the isonitazines that are opioids stronger than fentanyl. Fentanyl strips won't pick it up, and that can give you a false sense of security.
Yeah. I mean, it's always a moving target, but I think explaining what you're trying to achieve with the bill, it makes a tremendous amount of sense. And honestly, as well, speaking of what we were talking about earlier around how we are coding cannabis-induced psychosis, this will provide so much more information about who's actually, like, how many folks are actually having fentanyl in their system if we're testing for it. And like, goodness gracious, like 75 cents a test, that's such a small price to pay for information that's so valuable.
Right. And the biggest part it does, a lot of ear docs says, well, it doesn't change what we do. You're right. It doesn't change what we do, because what we do, and you've been in the ER, we're action oriented. I'm giving naloxone, I'm putting you on a ventilator. In that sense, it doesn't change what we do, but it changes very much the conversation that you have. If you extend the medical care a little bit more into prevention, like, do you know that you thought you were using methamphetamine, but you have fentanyl in your system? Then you see the patient's eyes light up. They're going to go home and do something differently. That may be what motivates them to change. And that's brings us back to the beginning of the conversation, is like, how are we interacting with patients in the emergency department at that touch point? Here's a touch point where that data point can really help change a person.
Mm-hmm. Yeah, well, absolutely, right. And I think that's almost we can broaden that out to all drug testing in a lot of different environments. It's about having clinically relevant conversations, giving people information, whether or not it has to do with, hey, did you know this was in your system? Or even, hey, you told me in treatment that you hadn't been using, but this test is positive. Do you want to talk about that a little bit? And where the lack of truthfulness was coming from. Like, it's all an opportunity for growth and hopefully positive change. So, all right, you convinced me. It's legit. It's not theater. All right, so let's pivot for a second here, over a little bit more to marijuana and cannabis. So you're one of the founders and current vice presidents of the International Academy on the Science and Impact of Cannabis, which, by the way, listeners, if you haven't gone over to the IASIC website, check it out. There's a bunch of amazing webinars, so much good information on there. I'm being slightly self-promotional. I'm one of them, but truly, like, you guys have gotten so many amazing speakers to share incredibly relevant information. I know that you mentioned that you've run into marijuana in the emergency department, and that's part of what led you to be vocal about this and form the organization. What are, in your opinion right now, your biggest concerns about what's going on with cannabis products and THC products nationally? And then where can we intervene? What are your goals with IASIC?
And thank you, Aaron, for actually being one of our scientific advisors for IASIC. I think it was important. There's a lot of organizations out there that asked us to help them, a lot of community organizations. I thought, wouldn't it be nice if we just had one organization of the doctors and scientists, and we can then help, anybody out. So I am proud of IASIC and the work that we're doing. What is the biggest problems? I think lack of information for the public, right? So if you're using alcohol, people know you shouldn't drive drunk. They should know about, it's going to give you cirrhosis of the liver, right? If you're using opioids, people know that's not healthy to inject things, or they realize if methamphetamine is not healthy. But people are told that using marijuana is healthy, it's medicine, it cures COVID, use it, for your pregnancy, nausea. There's all sorts of, terrible misinformation that affects public health with marijuana specifically, more than other drugs, because it's being commercialized. So I think that that's the biggest problem, is that the public has the right to know the risks, so they can make informed decision on use, right? And that's unique to marijuana compared to other drugs. The other part is the medical component of that has been just hijacked. I mean, I cannot recommend an aspirin or Motrin or an antibiotic without doing a history, a physical exam, drug interactions. I would lose my license if I did that stuff. And yet here, this is a medicine, and anybody with no medical education can promote it. They don't even know about drug interactions or patients' underlying liver problems that cause it hard for them to metabolize. I mean, we promote this as medicine in such a cavalier fashion. I think that's a problem.
Mm-hmm.
And,
oh my goodness, yeah.
And finally, the people who are making the rules have a huge business conflict of interest. Right?
Mm-hmm.
It's
oh my gosh, I could go on and on about Illinois specifically.
Right.
Yeah.
So I think they need to bring more follow the science, right? We need to follow the science when it comes to cannabis products.
Yeah, well, and I think probably listeners to both of our podcasts or followers who have seen us speak and talk know our feelings about this in general. That there's the cart is very much before the horse in a lot of areas around cannabis policy, whether or not we're talking about marijuana or medical marijuana or CBD or anything else, really. But I actually have a question, which was not on our outline, so I'm going to spring this on you. But a question about something that's been evolving, I think, a bit more over the past year and has caught my interest about the moving target in that industry in particular, which have been some of these, we'll call them more toxic and psychoactive extrapolations in a way of cannabidiol, your delta-8 THCs, and in particular now your THCO acetates, which, because they're derived from hemp and cannabidiol, are being sold in gas stations. They're not even coming out of dispensaries. And they're being hyped up on the internet. You can buy them, at any age, buy them on the internet. And I went to PubMed recently and I typed in THCO acetate, which is rumored to be up to 3 times as strong as regular THC. And I say rumored because you type that into PubMed and there's nothing. There's just zero research that's been peer reviewed on any of this. How do we start to wrap our arms around this as a society? Is this just something that's going to be out of control for a while? How do you feel about all that?
Well, this is not the same time. So I'd say the answer is also, let's look at history. So I remember when, with spice and bath salts came out, it's like, what is this stuff? I don't know what it is. It's legal. It doesn't show up on a drug screen. That's me as a doctor. The first thing I think of, well, how am I going to detect it as a doctor? How am I going to treat it? That's my first thing. It's like, okay, anytime there's something new, what do I need to do differently as a doctor? So it's okay. I won't find it on the drug screen. So I'm going to need to know symptoms. How do I detect it? So with these things, that actually scares me less as a physician, because I'll be able to treat that behavior, and what I do as a physician isn't differently. So in that sense, I feel more confident. So it's not, like other drugs I've seen, that I'm going to know what to do as far as detecting it. Now, the question is, how do we prevent it? So again, do we have the will? With spice and bath salts, we had the will. We went federally, and made those new stuff. We made a new drug, we made it illegal. Not only that, but all the associated products related to the spice became illegal. So we were able to shut it off at that end. And then I remember at the time, again, with spice, we traced them to certain smoke shops, closed down those smoke shops. We found them in different places, and we cut that off. So now the incidence of spice is much less. So we have ways of dealing with it. Do we have the will to do that?
Or an industry on the other side, which you made mention of as well. I remember back when the bath salts were big, and there were like the psychotic episodes that came. There was like one in particular I know that made an impact on me, where it was like it's like someone on a Greyhound bus decapitated another passenger in Canada somewhere, or something like some really intense.
Yeah, some homeless guy ate someone's face on a freeway.
Okay, yeah, that was like really, really bad stuff. But I don't feel I feel like the synthetic marijuana market and the bath salts, whoever was producing those things, didn't have the same bankroll behind them that we're seeing right now with today's cannabis industry.
Right.
So and that plays a big part as well.
Right.
Well, so let's ask. I'd like to ask you about that other bill that you want to speak about today, and that I'm interested in hearing more about, which is called the Cannabis Right to Know Act. It's an overhaul on marijuana labeling standards. So right now in California, what's missing? What don't consumers know? And what are you trying to accomplish with that bill right now?
So that bill, and I'm not the one who wrote that one, but I'm helping promote it. That's going to be a lot harder to do than the fentanyl one. That came about as really a copycat from Colorado. Marijuana has been legalized in California longer than Colorado, and hasn't had any consumer protection legislation at all since then. And a matter of fact, it's the opposite, right? During the pandemic, marijuana was essential business. Marijuana businesses are getting tax breaks. Meantime, you can't go to church or go to the gym or do anything else, right? A little bit backwards, right? I visited a dispensary I couldn't, the Walmart store was empty, but the dispensary was, rocking and rolling in California. Colorado was able to do that, to do labeling, advertising, and put some consumer protections. Very jealous of them and want to do something, anything in very pro marijuana business a state such as California. And this is what we came up with, that maybe we can get in. And again, to consumer protection and labeling has been effective in tobacco. So we wanted to do labeling for cannabis products. And again, it's about educating the consumer, making an informed consumer. So what's different now is they have like very small print, people don't really see it. And it has no mentions of mental health, psychosis and suicide. And I think that that's the greatest harms we're seeing is on mental health. And it said the biggest problem we have in our emergency departments throughout the country is mental health and holds on mental health. A percentage of those are from cannabis-induced mental health problems. There's a study quoted by Dr. Nora Wolkoff, the head of NIDA, recently in a presentation for SAM, the Smart Approaches Against Marijuana, where she showed data of people who have suicidal ideations, whether they have a cannabis use disorder, daily cannabis use, or no cannabis use, with and without underlying mental illness, with or without underlying depression, severe depression. And it showed that in all categories, people who have cannabis use disorder, daily cannabis use, have a higher risk of suicidal ideations. In San Diego, I have data from the medical examiner showing that THC is the #1 drug found in completed suicides in age under 25. Colorado shows the same. So again, consumer protection. This is being fought tooth and nail. I don't know if this will go anywhere. It passed Senate Business and Appropriations Professionals Group by 8 vote. It needed 8 vote, and we had parents who testified of the loss of their children. So nobody voted no, but there was a lot of just like abstain votes. And I don't know. Yeah. I don't know where this will go. We'd want to get anything a foot in the door for consumer protection in California. If we don't get anything in, again, it's a sad statement. And again, do we have the will? But what's more important, profits or public health?
Right. Well, and I think that's always the pivot when it comes to addictive and harmful products, right? On the one hand, you make more money the more people who use. On the flip side, it actually does cause harm. And it seems like, I know earlier in our conversation, we were talking about the nicotine industry and about how right now, like there's been so many clamps put down on tobacco in particular. I know things have been a longer time coming with vaping, and they're still playing catch up there. But it seems like our politicians, our policymakers understand that like less access and more regulation, less access, good labeling, all these sorts of things protect public health. And even if they would make money off of each pack of cigarettes sold, they're making the choice to say, nope, this isn't how we want to make our money. Yet then when you go on the flip side, and like, I'm here in Chicago, I'm sure it's the same by you in San Diego, where you've got billboards. I feel like a third or a fourth of all the billboards I see are for dispensaries.
So do we have the way? We have if we wanted to. I mean, we figured out the DNA of COVID in months, right? Like if we wanted to deal with this problem, we could. We're a smart nation. The question is, do we want to? Vaping is a perfect example. If we had, a medical and public health slant on vaping, they would never have been legalized. For every one person who maybe stopped smoking by using e-cigarettes, we created 80 new vapors who never would have in the first place. We created and unleashed a public health disaster.
Right. I mean, maybe even with the best of intentions, although I think that's questionable.
Yeah,
I remember seeing,
because those studies were in Europe. Those studies with the one person who's helped, those were European studies where smoking is much more prevalent than the United States. So,
Right. Well, and there's also this question of like, what happens when you put this product into the marketplace? Like, what happens then? I saw an article, this kind of gobsmacked me, about how there's a lab somewhere trying to develop a crack vape pen where they're trying to take crack cocaine and put it in a vape so that you don't have any like burned esophagus, you don't have, all the inhalation issues with smoke. And I was just thinking, I think that's probably like the worst idea I've heard in a long
Well,
time.
fentanyl in the vape, right? Fentanyl in the
Yeah.
vape. We've
Yeah.
had that. We've seen
Why
that
not?
too. Yeah.
Like, let's do all these products and just make it easily accessible to kids in a form factor that they're used to. Like, that's not going to backfire at all. Not even a little bit.
Right.
Oh man. Well, thank you so much. We're getting towards the end of our time here. I feel like I'm in therapist mode. We're getting towards the end of our time. But
You
is
have a
there
good
anything?
therapist voice, by the way. You have a good
Oh,
calm there. Yeah, I got that hyper ER doctor voice. Yeah.
well, thank you. But is there anything that you'd like to leave us with, like a parting thought? Doesn't have to be hopeful. It can be hopeful if you want, but just something to end on about from what you've seen and where we're going, how we can move forward.
I think it's important to be hopeful. There's always something you could do for anybody who's listening, wherever you are, whether you're somebody who has a substance use disorder or a family member, or if you're working on prevention or you're working on addiction or you're in recovery, there's something you can do in your own little circle every day. There's something to be grateful for, and impacting yourself or your own little circle. That's how we get things done. It doesn't have to be, a law, or we're not going to be able to fix the world, right? We can't do that. We can talk and complain about the problems, and we can only control ourselves and a little circle around ourselves. And if we do that, one person at a time, one day at a time, it's all important.
Yeah, well, 100%. And then some people, like, if your one person might end up in the ONDCP, or like some people I know starting nonprofits, or even if it's just helping people in your
Or the
community.
guy who's making food for the homeless out of his van. I mean, that's just inspiring.
It
Um,
all adds up.
yeah.
All right, well, that was very hopeful. Well, thank you, thank you for ending our chat on that note. Thank you so much, Dr. Lev, for coming on,
Thank
and
you.
thanks
And
everybody
thank you for
for
being on
listening.
my show too. That was amazing. This has been a good back and forth. I very much appreciate it.
Likewise. All right. Well, thank you everybody for attending, for listening in, and we'll catch up with you again soon. Take care.